Well, thanks very much for asking me to talk today, and pretty hard to follow on from a talk about sex, but I'm hoping I can make this sound pretty sexy. How's that? So good things come in small packages. I'm going to talk actually about prostate-specific membrane antigen, which is this new receptor that's been found on the prostate cancer cell surface, and it's really taken, I think, prostate cancer by storm in terms of how it's treated and how we're diagnosing it and how we're using it. So what we've got on that, now I'm going to use the right button, what we've got here is old technology. So this is a bone scan in someone who's got prostate cancer, and that's a lot of what we do still in clinical trials, and a lot of what we do in everyday medicine is to do bone scans to make sure that people are safe and healthy and don't have disease in their bones. And what we've got here on the right is what we call a PSMA PET scan, and that's a scan that directly targets the cancer on the prostate cancer cell itself, no matter where it is. So then we can see where the prostate cancer is, how much of it there is, and whether it's active. And it's thrown a real bomb into the treatment of prostate cancer, because a lot of the trials that have been done to date with all the new treatments that are around weren't done with this technology in place. And it's very hard for us as clinicians to know actually how to use that. And so we've been frantically catching up since this was introduced in Australia in 2014, figuring out how we should use this new technology, how it can benefit people with prostate cancer. So in fact, this is the receptor on the prostate cancer cell surface. And I see it sort of as a series of sticks on the prostate cancer cell, and we have these very, very clever proteins that we've been able to develop that bind very, very tightly to these receptors on the prostate cancer cell surface. And then these little proteins we develop, they bind, where's my little red gone? They bind to this, and then they actually fall into the cell. So that's how we get these beautiful images that we get. And it started off, really, this is a publication from 2012, and it's the first imaging publication that I can find in a mouse with PSMA PET. And then very, very rapidly it got introduced into clinical practice, and particularly in Australia and in Germany. So by 2014, we were offering this scan in Australia at a number of sites. And it's really interesting little receptor on the cancer cell surface. It's actually a growth receptor. So it's a bit like the androgen receptor. You've got a hormone receptor on the prostate cancer cell surface, and it's involved in helping the cell grow. Similarly, prostate-specific membrane antigen is also involved in helping the cancer cell grow. And that's one of the things that's very important when we interpret the scans. So when we first introduced it, one of the major things that we introduced it for was men who had biochemical recurrence. So the PSA was rising after radical prostatectomy. And to date, what has been happening for many years, those men that have had a radical prostatectomy, it hasn't worked. We know the PSA is rising. There's probably cancer somewhere. We know that 50% of those men will be cured if we give them salvage radiotherapy to the surgical site, to the prostate fossa. We know 50% of men will get cured, 50% of men won't. And so traditionally, that's exactly what's happened. But every doctor who's in that situation wants to know exactly where the disease is. How can we treat that? And that's been the first thing that we did, really, when we were looking at PSMA PET. And in fact, this is the very first PSMA PET scan that we did in my department at St Vincent's. This is the PSMA PET scan on the right here, and this is the scans that we were doing at that stage, which is a choline scan. And when we first started doing this, we actually did a prospective trial, and very grateful to all the men who were on that trial who had both PET scans within 2 weeks of each other. So they came back twice. They had the first choline PET, and they came back and they did the PSMA PET. And this was the first patient. You can see this little arrow here. X marks the spot, and this is a little lymph node that was removed surgically from this patient, and we said, yes, that is where the cancer is. And you can see on the choline scan, where, if I find my arrow again, where am I? It was negative. So we saw absolutely nothing on the scans here. We saw this node, we went, yes, we can actually see where this cancer is. We can know where to treat it, and it was a fantastic, exciting moment. And we actually stopped our clinical practice at that stage. Every single patient that we imaged with both agents, we found new lesions. They weren't where we thought it was going to be. And then we biopsied them, and every single one of them was true positive. It was actually cancer. So it was a eureka moment. But then we realised we didn't actually have the whole story. So this same man came back so he had surgery, his PSA went right down, but within 6 months, he came back with a PSA that was continuing to rise. And here we did his PET scan again, the PSMA PET, and we can see 2 new lesions. So we thought we'd treated him, we thought we'd found exactly where the disease was, but the disease is more clever than that, and in fact it had grown exactly 1 level above. So sometimes knowing where the disease is not enough. You've got to know about the biology of the disease as well and how best to treat that patient, and that's what we've been struggling with, and that's what we've been doing continuous trials with ever since. So we call that poker method. That patient actually got treated, but we didn't really help that patient. We thought we were, but we weren't, and that's what we've got to learn a lot more about. We have to learn how to use this really cool new technology in a way that actually better treats everyone. So we kept following all of these patients who we're imaging, and we have 1,500 men on a database in my department who we're continuing to follow up. And this is the men they'd had a radical prostatectomy, they'd had a rising PSA after that, and they went and had a PSMA PET scan. And the question is, if we did a PSMA PET scan on them, what treatment did they have afterwards, and did that actually help them? So we're getting some good data out now, and in fact we've got data for 3 years after the PSMA PET was done, looking at whether or not we actually helped those patients. So we've got 260 patients from this ProCanI database who had this specific indication, who had a rising PSA following radical prostatectomy, and the PSAs were at a level where they were still able to be cured, and we've got 38 months follow-up in them now. And we documented their treatment, and we also documented what their PSA was doing and how well they were doing if they were considered to be cured. And what we found is, strangely, if a patient had a negative scan but had treatment, the standard treatment to their prostate fossa, then they actually had an excellent response. 85% of those patients actually had a complete metabolic response to salvage fossa radiotherapy, while if you had a positive scan, you didn't respond so well. And that comes down to the biology of what that receptor is doing in the cancer, on that prostate cancer cell in the first place. So negative disease responded far better than positive disease. And these curves, what they show is they're out to 3 years now, very, very significantly. If you have a negative scan on the PSMA PET with a rising PSA following radical prostatectomy, you do extremely well with treatment. And if you have a positive scan, you probably need more extensive treatment in order to properly treat the disease. The other thing we found is we weren't really treating everyone appropriately. So men with biochemical failure following radical prostatectomy who had a negative PET were the men who were most likely to respond to salvage fossa radiotherapy, but they were also the least likely to receive that treatment. And I think that's psychological. As doctors, we see something, we want to treat it. As patients or men with prostate cancer, you see what you can see on your scan, you want to treat it. But it might be that we're not treating it entirely appropriately, and a lot of the work we're doing is working towards how we can better treat patients, and we need to do randomised trials so we can actually figure out exactly how best to do that, and that's what ANZUP is so good at. But not only are we doing imaging with these clever new proteins, we're also looking at therapy as well. So Theranostics, which is a new word, Theranostics is a therapy and diagnostic, and it really describes these new peptides where we can clip off the PET side of it, the imaging side of it, and we can clip on a therapy side of it. So we can use the same peptide that sort of attaches to the same receptor on the prostate cancer cell surface, and instead of taking a picture, we can actually treat that cancer. We can give it a targeted radiotherapy directly to the cancer cell, and we can actually kill that cancer cell using the same technology. So we use the screening to try and determine if patients are going to be suitable for that or not. And at the moment, we've got a number of trials that are happening around Australia where we're looking at men who have metastatic prostate cancer, so disease that has already spread outside the prostate, and who have already had other treatments like hormones and chemotherapy to see if we can help those men. So what we do on the screening, we do a PET scan, 2 different types of PET scans, and we look to see whether the receptor is actually on those on the cancer cells that that particular person has got, and whether it's going to be appropriate for therapy. And this is what we get. So this is a patient who was on one of the first prospective trials we did at St Vincent, and you can see this rotation these two things rotating here. This is after an injection of what we call lutetium PSMA therapy. So that's a therapy agent. Fortunately, it gives off a little signal so we can actually see where it all goes as well. So this is one day after the patient's been injected. This was a man who had extensive metastatic disease, prostate cancer with a really high PSA, who'd failed multiple lines of chemotherapy. And he had one injection of lutetium PSMA, and his PSA went down to 8 nanograms per mil. And you can see there's much less cancer there on the second injection than there was in the first. So he had a really good response to treatment. But not everyone does, and that's one of the things that I'm really fascinated by. Not the fact that we get successes, because we certainly get successes with this kind of treatment, but why we get failures. Like, what can we do to make it even better? So this is a patient also on this trial, and on his PET scan, which is what he had for screening, you can see that here, his PSMA PET, it was really nice bright disease. There wasn't much on the other kind of PET that we do. So this man, I would have said, would have had a fantastic response to treatment. I expected him to do really well. And you can see on our first image with lutetium PSMA, so the therapy injection that I gave him, that it got sucked up into all of those cancer cells. But they didn't die. And then he came back again and it got sucked up again. So really a lot of disease. We think we gave a really good radiation dose to all of those cancer cells, but they didn't respond. So they must be different types of cancer cells. They must be a bit resistant to radiation, and we need to know why one man responds really well and another man doesn't respond really well. And in my trial, we talk about treatment responses, how many men get a greater than 50% reduction in PSA. I got about 36% of my men actually had a very significant treatment response. But at another institution, looking at exactly the same men, they got a 56% greater than 50% reduction in PSA. And is that because the intensity of the scans when we screen them, is it a slightly different? The type of men that I accepted into the trial, were they slightly different? What is it about that? What is that difference? That means I can increase that treatment response so we can get good treatment responses in absolutely everything. One of the things that I think is that possibly some of these men have radiation-insensitive disease. That means you can give them a very high dose of radiation using this treatment to the cell, but the cell just doesn't die. So can we make them die by giving a radiation sensitizer as well? So that's one of the things that we're doing at St Vincent's, and that's the idea of using combined targeted treatments leading to a synergistic improvement in treatment response while minimising side effects and improving quality of life. So that's one of the trials that we've got ongoing at the moment, and preliminary results from that trial show that I've certainly done better in this cohort of men. I've gone from a 36% of men responding to 69% of men responding. So just by making small changes, by trying to combine things together, we can certainly improve what we do. And this is one of the men from this trial. So he was treated in November 2017, and this is his PET scan. So this is looking at the target, the PSMA target, and you see he has extensive disease in his bones, and he was very sick when he got put onto the trial. His PSA was very elevated. He came off the trial in August in 2018. PSA was 7 nanograms per mil, and June this year, his PSA is continuing to go down at 3 nanograms per mil, and he has 20 months on no treatment apart from just his hormone injection, hasn't needed any further chemotherapy, hasn't needed anything else. And he emails me occasionally asking why his PSA continues to go down, even though he hasn't had treatment for over a year. And I have to say, I have no idea. I have no idea why your PSA is continuing to go down, but it's great. So we have so much to learn. So we're doing a lot with ANZUP. The therapy trial is 10 sites around Australia. It's a really important trial for this kind of treatment. And what we're doing is we're doing a head-on comparison in 200 men. We're comparing lutetium PSMA therapy to men who have cabazitaxel chemotherapy, because we have to know, is it as good as chemotherapy? Is it better than chemotherapy? When should we be giving this treatment? Who should we be giving it to? And in what combination? So we have a lot of trials that we have to do. And then there's another trial that ANZUP's going to be starting shortly called ANZUP, which is also exactly about that. It's about predicting which men should be getting this treatment. It's about using very effective combinations of treatments to get a much higher treatment response in men. And it's also about trying to move the treatment earlier. So instead of giving it in men after chemotherapy, we give it in men before chemotherapy, because it looks like it's been quite non-toxic in the studies that we've done to date. So it's really what we call precision medicine, ANZUP, which is about targeting the right patient for the right treatment at the right time, predicting who we should give it in, predicting how well men will go, what we should give it in, and at what stage of the disease in extensive prostate cancer is it best to be given. So with the ANZUP trial that we're going to be starting with ANZUP, which is a randomised trial across Australia, just like the therapy trial, so it's going to involve 160 men. We're going to be doing a phase 2 trial, which is a randomised trial. We're going to get a lot of information on prediction using PSMA and PET scans. And we're going to do a lot of translational work in the lab to try and figure out why men fail these treatments and how we can stop men from failing these treatments. And that's all. Thank you.